Thank you very much for the introduction. So this is about going the distance in primary congenital glaucoma. The main site of resistance to aqueous outflow in primary congenital glaucoma lies at the level of the trabecular meshwork and the inner wall of Schlemm's canal. That is why angle surgery, namely goniotomy and trabeculotomy, are the standard procedures. The advantage of goniotomy is that it's done under direct visualization. It attacks the dysgenetic trabecular meshwork directly and does not jeopardize conjunctiva or sclera. The disadvantages, however, is that it requires a clear cornea, incisors 120 degrees of the angle only. It leaves residual TM leaflets, which can later on postoperatively fuse together and occlude the angle again. The results of conventional goniotomy in Western studies have been very good, with a success rate between 80 and 90%. However, in the Middle Eastern studies, the average success rate is about 50%. Trabeculotomy is an ab externo procedure. It is possible to perform in absence of cloudy cornea and incises the inner wall of Schlemm's canal as well as trabecular meshwork. It has the disadvantage of utilizing conjunctiva and sclera. Schlemm's canal may not be found in 3 to 15% of cases, and a false passage can be created. Again, the outcome of trabeculotomy in Western studies ranges between 80 and 90%, whereas in Middle Eastern studies, as reported by ElHilali and his co-workers in 2005, the overall success rate is about 40%. So why would angle surgery fail if the surgery targets the defective tissue so well? This is because there may be multiple mechanisms of outflow resistance. So in some cases, the outflow resistance may be present at the outer wall of Schlemm's canal, for example. Aggressive scarring of the angle may be taking place postoperatively, and that can differ in different racial or ethnic groups and can explain the difference of success and failure in different ethnic groups. Impairment of collector channels or even a more distal outflow impairment may also play a role. That is why circumferential angle surgery was advocated in order to incise the 360 degrees of the angle, increasing the success rate and also increasing the pressure lowering effect. So 360 degree suture trabeculotomy was refined by Beck and Lynch. They reported a success rate of 85% with a mean follow-up of 12.4 months. Circumferential angle surgery was compared to conventional or standard trabeculotomy goniotomy by Neustein and Beck in 2017. And it was much more superior success rate in circumferential trabeculotomy, 81% versus 31% in conventional angle surgery. However, the location of the suture was difficult to verify in opaque corneas using the suture trabeculotomy, 360 degree trabeculotomy. One or more cut downs may be needed to complete the 360 degrees. Suture misdirection into suprachoroidal space, anterior chamber, or subretinal space were also reported. With the advent of the flexible illuminated microcatheter assisted circumferential trabeculotomy, it became a much easier procedure with constant monitoring of the tip position, correction of false passage, accurate placement of the device in Schlemm's canal, and the ability to inject viscoelastic that can facilitate the passage through regions of obstruction. This study compares microcatheter-assisted, the 2-year results of microcatheter-assisted 360-degree trabeculotomy to rigid probe conventional trabeculotomy. It's actually from Cairo University Children's Hospital, and the overall success was much better in the microcatheter-assisted 360-degree trabeculotomy, 85% versus 50% in the rigid probe conventional trabeculotomy. Two-site trabeculotomy with the rigid probe trabeculotome was introduced by Lin in 1988 to disrupt 360 degrees of TM and increase the success in pediatric glaucoma. And again, in Cairo University Children's Hospital, the microcatheter-assisted trabeculotomy was compared to two-site trabeculotomy with the rigid probe, and both showed an overall success rate that was pretty similar. So ab externo circumferential angle surgery, whether using sutures, microcatheter, or a two-site rigid probe trabeculotomy, improves aqueous outflow through Schlemm's canal, has a higher success rate than conventional procedures, and avoids multiple angle surgery that could be needed. It has the disadvantage, however, of violating conjunctiva and sclera, oftentimes in more than one site to achieve 360-degree incision. Gonioscopy-assisted transluminal trabeculotomy is an ab-interno, minimally invasive procedure that results in a 360-degree trabeculotomy. It was described by Grover and reported by Grover and his colleagues in 2015 on 14 eyes with uncontrolled primary congenital glaucoma and juvenile open-angle glaucoma with gonioscopic findings of angle dysgenesis, and the mean intraocular pressure was reduced from 27 millimeters mercury to 14 with a mean follow-up of 20.4 months. So this is the surgery. The central edematous corneal epithelium was swept after a drop of 70% alcohol was used. The tip of the proline suture was blunted with heat. Viscoelastic was introduced into the anterior chamber, and 2 clear corneal incisions were made. A 27-gauge needle was then used to create a 3 o'clock hour incision in trabecular meshwork and the inner wall of Schlemm's canal. And the 23-gauge forceps was then introduced to grasp the 5-0 proline suture, and the blunt tip was then introduced into the lumen of Schlemm's canal. The 23-gauge forceps was then used to circumferentially advance the 5-0 proline suture within the Schlemm's canal, and this was continued until the blunt tip appeared. It was then grasped with 23-gauge forceps, and the outer suture was then pulled to create the incision in the inner wall of Schlemm's canal and trabecular meshwork. This is the appearance of the angle at the end of the procedure. This is another procedure in which the microscope-mounted OCT was used. Blunt-tip 5-0 proline suture was introduced into the anterior chamber, and the 27-gauge needle was advanced across the anterior chamber. Prior to the incision, OCT was used to visualize the angle. You can see amorphous tissue occluding the angle in the lower image. The incision was then made with the 27-gauge needle, again involving the trabecular meshwork and the inner wall of Schlemm's canal for 3 clock hours. You can see the shining appearance of the outer wall of Schlemm's canal here. OCT was used to confirm that the incision was really made in trabecular meshwork. This was followed by introduction of a 23-gauge forceps to grasp the 5-0 proline suture, introducing it into Schlemm's canal. Minor resistance to obstruction, as you can see here, can be bypassed by applying a push on the 5-0 proline suture, which is then continued to be advanced using the 23-gauge forceps. This was continued circumferentially again until the tip reappeared from the other side. It was then grasped with the forceps, and the suture was pulled on the outside to create the incision again in the angle for 360 degrees. And once the incision was made, the OCT was used to confirm that the incision did actually occur. This is the temporal angle, and you can see here the OCT showing that the incision in trabecular meshwork has been done. And this is seen in the lower image. You can see that we did that again on the nasal side. Again, the lower image confirms that the trabecular meshwork has been really incised. So the GATT is a minimally invasive ab-interno procedure. It incises 360 degrees of the angle. 5-0 proline or a microcatheter can be used in children. It eliminates conjunctival and scleral dissection. There is a learning curve, but surgeons who are used to goniotomy learn it faster than the surgeons who have been using the ab-externo trabeculotomy. It requires clear cornea. Intraoperative bleeding obscures the angle but can be flushed with viscoelastic, and an incomplete passage can also occur. So where do we go from here? We know that circumferential angle surgery yields better surgical outcome in primary congenital glaucoma, and that is why surgeons should be willing to go the distance and to perform circumferential angle surgery, especially in the aggressive types of primary congenital glaucoma that we encounter in the Middle East. We should be looking at ways to diagnose distal outflow dysfunction, and maybe with the improvement in anterior segment OCT technology, we might be able to do that. We should be looking at ways of reduction of incision scarring And currently in our establishment in Cairo University Children's Hospital, we're using anterior segment OCT postoperatively to better understand failure mechanisms. Thank you very much.